Thank you very much. It's always a pleasure to come to Dr. Rajiv Chaudhary's course. Only thing, because I have a course running downstairs, for the first time I wish that it was not 2 floors up.
You always go.
Always hope. So, anyway, this is just running through some of the, excuse me, just 1 minute. Now, this was a case of a young patient with a traumatic cataract and a very fibrous capsule. Was insistent to have it surgery done on a femtocataract platform. So I initially planned the rhexis to come beyond the presence of the fibrosis. He had some astigmatism, so I had used arcuates to debulk the astigmatism, which it does do to an extent, though not to the exact precise levels. And the femto disruption occurred, and I was really hopeful that it would actually manage to get a good rhexis. Opened up the incisions because it's important to open the arcuates before we start the surgery. Normally I would never inject Trifen Blue, but I have injected Trifen Blue to try to understand how much of the rhexis is in fact being cut. And I was quite pleasantly surprised that although there was a fibrous girdle all through, it was only in this area where the fibrosis was really tough that it was stuck. And I tried valiantly to push with my cystitome, but it's so obvious that I fool around a little more, I would end up with a zonular dialysis and a traumatic cataract at that. You never know, a dialysis may be sitting quietly in a corner. So that's when you realize that our manual instruments, the conventional methods have to be there on the tray so that you could go ahead, and then I cut it curvilinearly along the direction of the rhexis. The cataract looked quite hard, so did gentle hydro to loosen up the nucleus. I thought that was the next ominous task in front of me, but you wouldn't believe it. As I rotated, I realized it was nothing but just a thin disc. Naturally, the patient was young. It was just a complicated cataract which had this brownish hue. So I went on to the flip mode, which is available on the Centurion machine. It does get a little supracapsular, but the whole thing is out in no time. So I realized that this area of fibrosis is there, maybe just do a little PC polishing, and the challenging case was actually, it's going to get done. There was nothing to it. When I found that the PC was getting caught by the aspiration cannula, I went in with the infusion and separated it. But then again, at another point, it got caught. It was quite clear that this was a totally friable capsule. So what next? Do I just hold on to the capsule for what it's worth, or why not iatrogenically create a PCR is what seemed to be makes sense, because this kind of a capsule cannot be a scaffold for an IOL at all. So went ahead and did a good anterior vitrectomy, clearing the vitreous, the debris, clearing the visual area. And of course, the tricot always comes to our rescue to let us know that whether aberrant vitreous has not been cut. So, and it also has an anti-inflammatory role at the end of it if a little bit has filled into the posterior segment, and then enlarge the incision and balloon up the space in front of the rhexis as is being done, and place a 3-piece IOL in the bag. If you can, do an optic capture, and that's the best way to go about it, and this situation got dealt in this manner. Then going on to the next setting. Very sorry. Oh my God, what am I doing? So, I don't know, I'm going on to the case discussion. There's one other video. आप आ सकते हैं कोई? जल्दी आइए ना, एक दूसरा वीडियो दिखाना है, उसके बाद डिस्कशन हो सकता है।
It's okay.
ये बंद नहीं हो रहा है, ये बंद कर दीजिए इसको, बंद कीजिए। No, he has to. One more to go. तीसरा. Very sorry, doctor, for the delay.
No problem.
Yeah. Now, this is again another situation. Often cataract surgery sometimes becomes like a chessboard game when you wonder whether you're going to be hit with the dwarf or whether the king is going to win. And this was some kind of a similar situation, which started off as a very routine cataract surgery, but then a well-dilated pupil at that, created the side ports. One of those last cases where you think you can rule the world, injected viscoelastic, got a nice round rhexis. And I expected that surgery should go optimally. There was no excuse for not dealing well with this kind of a hard cataract, a soft, moderate cataract, a gentle hydro, a multi-quadrant hydro if necessary, but it always makes sense to decompress the bag now and then, inject viscoelastic to coat the endothelium, and go ahead the usual way, the intraocular pressure that's sitting at 60, the best of machines, and I do my first phaco chop, and feel quite comfortable that it's done, that half the heminucleus is cut, and then go on to make one more chop, and I think it's time to eat up the nuclear fragment when I notice a PCR, which has got probably inadvertently created by my phaco chop maneuver. So then what next? So I just go back and inject the viscoadaptate viscoat, which would push the vitreous back. And it's quite clear that the vitreous is not presenting at this moment. So I bring the nuclear fragments up. So if there was mixed with vitreous, this would have been a challenge because that would have tugged on the vitreous at the base. So anyway, things were fairly okay. Again, go back and inject viscoat. And then, yes, I could have used IOL scaffold, but I was just trying to show you that sometimes we think we are quite brave enough. The area of PCR has increased. I just use my second instrument as a scaffold, bring down the phacoparameters, and supracapsularly get done with this. I was lucky here, but then now I would go and do a good vitrectomy as a little bit of vitreous was already presenting, and then go back to remove the cortex, and the ease with which you remove the cortex is actually a clear indication that your vitrectomy has been done well. And once that is done, once the vitreous is clear, there's no debris lying around, now all I have to do is just inject a viscoelastic in front of the sulcus, balloon it up, place a 3-piece IOL, and now this was a nice round rhexis, do an optic capture, and then you have a centered IOL. Yes, you need to go behind the IOL because you really need to clear the vitreous. You can't afford to have any strands. You could even inject tricot to see whether everything is all right and do an optic capture, and you are in the best kind of situation even in these moments. Do I have time for a case discussion?
No,
It's up to you.
just one or two comments. I mean, the first video you showed where you did
Yeah.
the vitrectomy and cut the capsule
Yeah.
while there was no PCR.
Yeah.
So whether, using CTR will tighten the capsule? I mean,
No,
put on a CTR because
yes,
the posterior
CTR
capsule
would
was
tighten in
floppy.
subluxated cataract, but this was
Yeah, I know, I understand
it was
because
so
the capsule was
friable.
floppy.
Yeah,
I have seen many a floppy capsule,
Yeah,
we put
yeah,
on a CTR, it becomes
yeah,
tight.
yeah.
So you can
So I
use
don't think the CTR and an IOL, the posterior capsule could have held all that. It would all gone into the vitreous. So this is one extreme situation wherein that was the only
No,
solution.
not in this case, previous case. In the first case where you did, the capsule was coming into your phaco probe.
That is what. The posterior capsule was so friable. It was just folding up. It wasn't it was not that
No,
kind
no,
of a capsule
the
of a
capsule was not
subluxated.
friable. If it was friable, it was a broken when it was caught. Capsule was lax. And the laxity can be tightened by the CTR.
True.
So that was the point.
Yeah.
And second point was, whenever you put tricot, I usually prefer to put on a tricot after placing the IUL so that it doesn't go into the vitreous cavity. In this case, like a lot of the tricot gone into the vitreous cavity.
Yes.
So I put the IUL and it was a planned vitrectomy.
Yes.
So even if required, can be done through the pars plana.
It was not banned, yes.
Okay, thank